traditional territory of the Coast Salish people, specifically the Samish and Swinomish people, and pay our respects to elders past, present, and future. If you're not on the mailing list and would like to be, please sign in the back, add your email and phone number, and we'll put you on our email list, and so we'll let you know about our meetings and what's going on. We do not send out a lot of emails, so you're safe. Just to let you know, the library is closed tonight, but we can use these two doors, and the bathroom is open, so that's the back door into your room. I'm going to turn off your cell phones. Let me make sure I say that in one of my rings. Mine is silent. Okay. There are some wonderful cookies in the bag. Thank you, Rita, again. Yay. And there's also some teas and chocolate mix and some decaf coffee. I want to tell you a little bit tonight about us. We are, the Finova Democrats are an independent democratic association with a focus on education. I want to remind everyone we are not a PAC. We cannot endorse candidates or contribute to their campaigns. We do invite Democratic candidates to talk about issues and legislation. The elections are over, but if you want to contribute to candidates or get involved in their campaigns, we encourage you to go to their websites. And the meeting is being recorded by Rita Sullivan, and she will be sending out the recording to our YouTube channel. So if you know people who are interested and didn't make it tonight, let them know that they can catch that in a few days. We don't charge dues, but we do pass the hat at some point, and I want to thank you in advance. We have donated in the past to the Southern Poverty Law Center, the Central World Kitchen. We also work the Brick Dinner at the Presbyterian Church every couple of months. And this month we're going to be discussing the money that we have that we've collected over the last 6-8 months to give to some local groups with a focus on food insecurity, in other words, hunger. And so we haven't decided which groups yet, and but we're going to keep the money local, and that's going to be the focus of the money that we have. I wanted to let you know we are not meeting in December. I'm sure you all should thank us because everybody gets so busy. And so our next meeting is going to be in January. The second Tuesday of the month was the January 13th. It'll be at the library here. And we have not decided on a topic yet, so that will be announced. And you'll get, if you're on our mailing list, you'll get the email with the flyer telling you what we're up to. Ongoing rallies. We're still having rallies. Thank you, Sarah, for
moving to 12th.
Yeah, I was just gonna say.
Tomorrow.
We have
Back to
been meeting.
Safeway.
Yeah, and of course, stands up. There's cards in the back if you're interested, and information that's, so it's Sunday from 12 to 1 and Wednesday from 3 to 4. And that is going to be back at our old place in front of Safeway.
Where is it tomorrow?
Safeway.
Safeway, we're back to Safeway.
Yeah.
So,
We get to practice on a MAGA-free day and before we do our first Sunday.
right, yeah, just remember on Sundays, we have the magas over at the corner there.
All three.
Right, no, well, whatever. So, don't aggravate yourself if you come. Okay.
There's so few of them.
Yeah. Hopefully less and less. I also recommend if people are interested in just getting general information, the Skagit Democrats and the Whidbey Island Democrats have newsletters that come out, and you can get on their websites and sign up. And they're full of really interesting, good information about what's going on. And so if you have a group and want to be in their newsletters, you can email them and let them know what you're doing. So, and we just encourage you to do that. And we also encourage you to join groups and organizations that you're interested in that you might want to be helping. And before I introduce Jeff Johnson, who is the co-president of, this is Advocates for Retirement Action. PSARN. If there are any elected officials here, please stand up and raise your hand. Laura.
Oh.
You're in, this is Laura. And the PCOs.
But,
Oh, yeah, and there's a PCO.
yeah, Pam and Rita are PCO.
I was recently elected to the Cedar Lake City Council, will be starting in January.
Yay.
Okay, so I'm gonna, Jen has got quite an impressive resume, so I thought I'd read some of it. And I'm gonna start by saying a little about the group, the PSARA. They're very active with legislators, and they focus on protecting Medicare, Social Security, Medicaid. And they also, when you get their newsletter, they also have a lot of other issues: climate, environmental justice, race and gender equity, government relations, multitude of concerns about foreign issues. So it's a pretty wide range of articles that they have. It's a really an interesting little bulletin that they send out. It's 8-10 pages. It's really worth getting. So that is that. When the screen goes up, you can see that. And Jeff brought a bunch of literature, so I'm sure some of that has the information. And you can always go online. You know. So then I'm going to talk a little bit about Jeff now. He served as president of the Washington State Labor Council, the AFL-CIO, from January 2011 to January 2019. He first joined the Washington State Labor Council staff in 1983 and served as staff for 25 years before being elected president. His union life in New York City with Local 2190 of the American Federation of Teachers, AFL-CIO, in 1979. He has taught labor economics and labor studies at the Harry Van Ardsdale Center for Labor Studies, Empire State College, State University of New York, as well as Congress for Neighborhood Women.
I think you're reading the bio my mother sent.
Oh, it's great. I mean, we need to know that our people that are involved with groups have been active in the past, and they've just continue to be active, which is just wonderful. The International Ladies Garment Workers Union, and other labor and community-sponsored education programs. In 2015, Jeff was part of the U.S. labor delegation to the Paris climate talks. Since then, he has led Washington unions working with communities of color, tribes, the environmental community, and other progressive organizations to build equity, labor standards, and a just transition into strategies to combat climate change and inequality. In addition to co-leading the Washington State Blue-Green Alliance, Jeff represented labor on the governing board of the Alliance for Jobs and Clean Energy. The Alliance wrote and ran the climate initiative I-1631 in 2018. On a personal level, he lives on the San Juan Islands with his wife, who's here, Rebecca, and they have a small organic flower and garlic farm and work on immigrant rights and food insecurity issues. And Jeff is the co-president of PSARA. And the other thing is today is Jeff's birthday. The steering committee is going to give him a card.
Thank you.
We thank you for doing that, and thank you for Becca for being agreeable to that. So, all right. So with that, I'm going to let Jeff take over and let us know about what the current topic is tonight. Thank you.
Oh.
And you have
Yeah. Let me try it without the mic, and if you can't hear me, then I'll use the mic.
For the recording.
Oh, for the recording. Gotcha.
So
Okay.
I'll show you.
Please.
Yeah, this one's a little different.
Did you say you wanted the screen up? We had something.
Thank you very much, Barbara. It's an honor to be here. Thank you for thinking of Passara. You definitely had the bio my mother sent, and I'm a little bit embarrassed, but thank you for the kind words. And you took a good deal of my introduction, so I didn't mean to do that. But what I do want to do is say this. So I brought some literature from Passara for you. There may be copies for every one of some of them and not enough of others, but I just wanted to point them out to you. They're for yours to take. This one is entitled Give Us a Real Choice, and it's an effort that Passara, Pew Center Advocates for Retirement Action, we've been working on reforming Medicare for the past 5 years as Trump won and even the Biden administration put forth efforts to further privatize Medicare. And we took on a strategy of, and I'll lay my cards on the table, we advocate for a Medicare for All program, universal health care, right? But we also think that probably the best way to get there is by leveling the playing field for Medicare so that original Medicare, which my wife and I are a part of, has the same level of benefits, the same cost structure as Medicare Advantage programs. Rather than straight out attacking Medicare Advantage programs, because some of our members have those programs and they like them, we thought let's go another route. Let's level the playing field, make it competitive, and the public system, we believe, will win out if there's a level playing field. Anyway, this book, there's about 14 different essays in this book written by all sorts of folks, scholars, labor leaders, social activists from around the country, with an introduction from Congressman Pramila Jayapal. This has more information on Medicare than you probably ever want to know. It's a great resource. Anyway, it's for you. The second piece just came out on Labor Day of this year, and it's called Protecting Our Assets, Protecting Our Asses. And basically what it is a set of essays that make the argument that the Washington State Investment Board, which invests all of our public employee pension funds, but as well as pension funds for labor and industries, crime victims and others, that they would be better off if they divested out of fossil fuel investments and put those investments into life-affirming assets, both for moral reasons, political reasons, social reasons, but as well for financial reasons, because fossil fuels have underperformed almost any other asset for the past dozen years or so. Anyway, it also has an introduction by Congressman Pramila Jayapal. There's a theme here, and quotes from various endorsements from various other leaders. Then I also brought one of the latest issue of the Retiree Advocate. This is the monthly newsletter that we put out. It's a 12-page piece. If you become a member of Passara, you would get this either in hard copy like this or electronically or both. I get it both ways. And again, we draw in writers from all around the state, all around the country on a variety of topics. This one has quite a bit on Medicare and the WISER pilot program that Washington State is programmed to begin in January. We'll talk about it in a little bit. And finally, this is our little promotional brochure. Kind of gives you a thumbnail sketch of what we do at Passara and the types of webinars we hold and the Retiree Advocate. And there's a form to fill out if you would like to become a member of Passara. It costs $20 a year, $15 for lower income folks. It's I think, a pretty good bargain. Anyway, so that's my pitch. So what I was asked to come and talk to you about tonight was basically threats to Medicare and to Medicaid. So I thought I'd start with just a brief history and kind of outline the differences between original Medicare and Medicare Advantage, and then the continuing threats that we're facing today. So both Medicare and Medicaid, of course, were established in 1965, and they were part of LBJ's Great Society program, and it was actually part of civil rights legislation. Okay, this was in the context of decades of civil rights struggles and an awareness of increasing income and wealth inequality in the United States. So Medicaid, of course, was to provide health care for low-income individuals and families, and Medicare to provide health care for seniors. Because at that time, in 1965, nearly half of all seniors in the United States had absolutely no health care whatsoever. And low-income folks, more often than not, had to rely on charity care at hospitals and emergency rooms to get their health care. Now, the thing is, it was not easy to pass. It's been under attack since it was first introduced. And so to get Medicare passed, LBJ had to cut a historical compromise to get it passed. Opposition to it came from the medical industry, from the insurance industry, from white Southern senators, federal senators. So the compromise came out this way. Originally, Medicare would have paid for 100% of our healthcare needs. It would have been universal free healthcare. The compromise was that Medicare, original Medicare, would pay for 80% of our coverage, okay, for Part A, hospitalization, Part B, doctor's office and specialists. And the reason why 80% was, and why 20% of the cost would be paid by individuals was because Southern senators said, well, let me take a step back. LBJ said, as this is part of civil rights legislation, to accept Medicare dollars, doctors' offices, hospitals, had to allow everyone to come in. They needed to desegregate their offices, their hospitals, okay? So Southern senators said, fine. Individuals have to pay 20% of the coverage because in their way of thinking, low income, black people wouldn't be able to afford the coverage. And therefore there'd be less of them going into their local hospitals and doctors' offices. So the compromise had its roots in racism, but it was the only way that LBJ could get this piece of legislation passed. The 20% also benefited the insurance industry because most folks, particularly if you had catastrophic illnesses or injuries, you can't afford that 20%, right? So it created an opening for the insurance industry to come in and sell people Medigap policies, all right? And to sweeten the deal for Medigap policies, Medicare allows these insurance companies to take 22% of every Medicare dollar going to them for administration and profits. I don't know how many of you have been in a business, but a 22% profit rate is pretty damn good. And just to give you an idea, so the Medigap policy my wife and I have is through Regents Blue Shield. And we pay on an annual basis about $6,600 for that policy, right? Yeah, and it's a decent policy. But right off the top, before any doctor's visit, Regents gets $1,500 of our money every year for doing nothing. So anyway, that was a historical compromise. So original Medicare, I just want to do quick the pros and cons of it so you get a sense of, what we're trying to save and what we're trying to expand from, okay? So I should ask this, how many people are on original Medicare in the room? Okay, that's good. How many are on Medicare Advantage programs? Okay, and if you like your program, that's great. And if it's working for you, that's wonderful. But I want to walk through kind of the trajectory of the attacks on Medicare, and the corporate backers of Medicare Advantage are leading this attack. Okay, so the pros for original Medicare are this: is universal coverage. Anyone over the age of 65 is covered, as well as those disabled under the age of 65. It's universal. You can go anywhere to any doctor, to any hospital that accepts Medicare. And over 90% of physicians' offices accept Medicare. Over 95% of specialists in hospitals accept Medicare. So it is as universal as you get. It's a very simple and efficient system. Medicare, through the Centers for Medicare and Medicaid Services, pays your doctor's office or pays the hospital directly. They submit a bill, boom, a check goes out, it's done. It's cost effective. The administrative cost for Medicare, original Medicare, is 2%.
Wow.
So basically, 2 cents out of every dollar goes for administration. There are no profits in original Medicare. So that means 98 cents out of every Medicare dollar in original Medicare goes to healthcare services. Finally, and this is the part that is really critical and the part that we're perhaps on the brink of losing, is that medical decisions are made between you and your attending physician. You decide what's right for you. And I'll give you an example. So a year ago, I had a hip replacement done, okay? And you know, I worked with my attending physician out on San Juan Island, and back in around June of a year ago, this past June, I said, Doc, man, I'm hurting, you know, I'm limping. And we thought, okay, it must be my knee. So we had x-rays done, and the x-rays came back. You know, it was narrowing, but it wasn't enough to justify a knee replacement, right? So scratching our heads, well, what could this be? And then we thought, maybe it's the hip. So got hip x-rays done, and sure enough, that was the problem, right? So I talked to friends. They told me about great surgeons in Seattle, great surgeons here in Anacortes and Mount Vernon. I said, great. So I called both offices. Said, when can you get me in for a consult? Seattle one said, you know, oh, in 35 years. No. I said, you know, they said about 4 months out. I said, well, no, I'm hurting. So I called Stacia Smith's office here in Anacortes and Mount Vernon. Some of you may know her. She's wonderful. Very dry sense of humor, and really appreciates garlic too, which is wonderful. I paid her in part in garlic that I grew, but she was wonderful. She said, yeah, you know, I can see you in about a month and a half. So I went to see her, and I said, okay, we're picking that one. No prior authorization needed. It was just my doc and I decided that was the right thing to do. The X-rays proved that I needed it. Called her, boom, we scheduled surgery. It was done. Very, very simple. Original Medicare, the way it's paid is fee for service, okay? So that each service has a fee attached to it. And whatever the fee is, that's what Medicare pays, and it's done. Now, I said that from the beginning, the insurance industry was cut in. That was part of the historical compromise. And over those 15, 16 years, between 65 and 1982, the insurance industry was saying, this is a pretty good deal. There are a lot of profits to be made in Medicare. So they have one of the most powerful lobbies in the country then and still now. And so they lobbied the Reagan administration to expand Medicare to what's now called Medicare Advantage. They wanted to privatize Medicare. Now the Heritage Foundation, the ones that created Project 2025, right? You know, that traces itself way back to Justice Powell's, well, before he was Justice Lewis Powell's, the Powell memo back in 1971 that he wrote for Richard Nixon, which basically outlined how the conservatives could take over education, how it could take over kind of the public space, how it could reduce regulations, how it could privatize many government functions. So in 1982, this was kind of the fulfillment of part of that dream. It was, okay, we're going to create Medicare Advantage and allow private insurers to go beyond Medicare and actually administer full Medicare claims. So what did this do? It immediately broke the key part of original Medicare, which is medical decisions are made between the patient and your doc, because now there was an insurance person standing in between the two of you. You and your doc may agree on something, but then the decision had to be sent to the insurer, and they decided whether, you know, that hip replacement needed to be done or not, when it was done or not. So they needed a justification for this, and this was the hardest part. And it was kind of the justification was accepted on a bipartisan basis. Many Democrats, almost all Republicans, they attacked the fee-for-service model. All of a sudden, original Medicare became the problem. What they said was fee-for-service creates an incentive for docs and hospitals to simply pile on services, because more services, the more fees, the more money they make. So they basically said greedy doctors, greedy hospitals, That's why we need the private sector to come in, because everyone knows the private sector is more efficient than government. So it fed that whole mythology that everything is better in the private sector, okay? And what they created instead was a very complex, very inefficient, and a very costly private health system. It's not really Medicare, it is private health care for seniors. You've got Medicare, the Center for Medicare and Medicaid Services. They pay insurance companies, and there are 10 of them that control 80% of the Medicare market, okay? And each one of those has a multitude of medical networks of doctors and hospitals, oftentimes very narrow networks. You can't use a doctor outside of the network or hospital outside of the network unless you're willing to subsidize it yourself. And the crazy part is each one of these networks has their own set of proprietary rules regarding services. They're not universal from one to another. And that's one of the reasons why people get really confused and why you see every October during open enrollment period, and you see, you know, former football stars like Joe Namath and, you know, all sorts of, you know, B-grade actors, you know, getting on TV to extol the virtues of different medical advantage programs. Well, they are all different and offer different benefits. Here's the key. They're paid right off the top, 15%, okay, for profit and administration. Remember what I said about original Medicare? 2% for administration. All of a sudden, Medicare Advantage, you get 15% off the top for administration and for profits. Okay, what are the pros for Medicare Advantage? And there are serious pros. There's no Medigap policy, right? So monthly premiums average about $20 a month. Average original Medicare costs are $200 a month. So think about that. If you've got a tight budget, if you're on a lower income side of it, it's not a hard choice, 20 bucks versus 200. It's like, I'm doing 20 bucks. There are extra benefits that they're allowed to provide, which original Medicare right now is not. So limited vision, dental, hearing, transportation to the hospital, little home care services, silver sneaker gym memberships, stuff like that, right? It's good stuff. Could be better, but nonetheless, original Medicare doesn't have it. Cost of prescription drugs is oftentimes either no cost or low cost within Medicare Advantage programs. It's a real benefit. Out-of-pocket expenses are capped at $8,300, okay? What I didn't say to you, I haven't done this in a while, is on original Medicare, there are some negatives to it. Obviously, Medigap, you know, the 20% costs paid for the insurance we already mentioned. $1,600 deductible for hospital visits. There's no limit on out-of-pocket expenditures, so that can get quite pricey. And then there are premiums on your Part D, your prescription drug programs, okay. So seem to be a lot of advantages to Medicare Advantage over original Medicare. If you can get over the fact that you and your doctor no longer are making your key decisions and somebody else is. What are the cons of Medicare Advantage? Well, you need prior authorization for anything, okay? So again, it's the decisions are no longer yours and your doc's. So I have a friend on Whidbey Island, okay, that looked at the calculus and he said, Medicare Advantage, I'm gonna do that because I think I'm gonna come out better financially, right? And then he had a knee problem, and it actually was a knee replacement he needed. There was a doc in Seattle he wanted to see, and he happened to be in the network for this Medicare Advantage program, set it up. 2 weeks before the surgery, that doc was dropped from the network. He was told, surgery off. He had to pick someone within the network. So he found someone else within the network, had to reschedule stuff, so it was more delay, more pain. He got it done, but nonetheless, he was happy with the final outcome. 6 months later, he had a growth on one of his ears. It turned out to be malignant melanoma, okay? And so he and his doc said, you need to see a specialist, a dermatologist, right? He was denied by the insurance company. So they appealed, he was denied again. They appealed again, 7 months later, okay, as this thing was growing and getting more painful, they finally said, okay, you can see a dermatologist. That's what they found out. It was malignant melanoma. He had to have major surgery. He was not happy. This was not a good outcome, and something that had he been in original Medicare, they would have seen the dermatologist right away. They could have prevented all this trauma from happening. The networks are limited, okay, and they have restrictions. They have different proprietary rules, as I mentioned. Now we're seeing an increasing number of attending physicians are refusing to accept Medicare Advantage patients because of the denials and the delays. Because docs don't like that. And I don't know about you, but I really like my attending physician. You know, you get to know them and they want the best care for you, and it's part of the Hippocratic Oath, right? And they don't like to be told by an insurance person, no, you've made the wrong call, right? So they don't like it. But then finally, Medicare Advantage programs are bleeding the Medicare Trust Fund. They are draining it tremendously. Now, why do I say that? Am I just making that up? So the Inspector General for Health and Human Services back in 2022, good, it's late. Getting old, I just turned 74. But this is back when we had Inspector Generals, right? And with Trump 2, it's like we have fewer and fewer of these. Well, so data from the Inspector General's report, from investigative journalists, from whistleblowers, and also from lawsuits, we learned that Medicare Advantage programs defrauded the US government, the Medicare Trust Fund, from us as US taxpayers to the tune of $125 billion between 2008 and 2022. And in the year 2022 alone, it was $23 billion of fraud. Estimated in 2024, that figure had risen to $84 billion in overpayments, or again, defrauding the Medicare Trust Fund. So how does this happen? Remember I said original Medicaid is fee for service? You know, gotta have a hip replacement, there's a fee for it, that's what gets paid for. Not so in the Medicare Advantage system. What they base payment on is a capitated basis. So the average beneficiary in a Medicare Advantage program is valued at $5,000 a year. Now, if your underlying health profile is more severe, there's formula and also risk factors. It could be as high as $10,000, or it could be as low as $3,000, but the average is around $5,000. The thing is, every dollar that is not spent of that $5,000, $10,000, $3,000 just goes right into the pocket of the insurance company. So there's a bit of an incentive to not give as many services, not allow as many services, because they don't want to blow through the limit, whatever it is. Thus, the delays and the denials. But then there are also other things that they do. And I know this is going to sound crazy and ridiculous, because you're going to say, Jeff, you're telling me something that common sense says this should have not gone on. But they upcode. Has anyone heard the term upcoding in terms of medical services? No, Laura has, of course you have. Laura, I've known Laura for, I don't know, 30 plus years when she worked down at Labor Industries in Olympia. Great friend of working people. So upcoding is very simply making people appear sicker than they are. Why would you do that? Well, because you want a higher capitation for that individual, rather than the 5,000 average. If you can get up to 8,000 and then not provide them those services, or determine later on that not all of those services are actually necessary, there's more money to pocket. That's where we get the $125 billion, the $84 billion in 2024. Most of it comes from upcoding. It is outright cheating, it's outright fraud. They also cherry pick. There's a whole set of insurance brokers that are paid to direct people into Medicare. If anyone in this room has to make the decision right now of which to go into, all right, go to SHIBA. SHIBA is the part of the Washington State Insurance Commissioner's Office that has experts on Medicare and can help guide you through these complicated decisions of what plans to pick, and it's free. Insurance brokers are paid to give you information on Original Medicare, Medicare Advantage, and other programs, but they are paid differently. They are paid right now $500 if they steer you towards the Medicare Advantage program. They're paid $300 if they steer you towards Original Medicare. That's in the first year. If you stay in the Medicare Advantage for the next year, you get $400. You get paid, if you stay in for the third year, they get a lower amount. I don't remember what it is. So there is an interest, a financial incentive for them to direct you towards Medicare Advantage programs. And what they do is, you know, they're looking at your health profile and they want to pick those people with the best health profile to go into Medicare Advantage programs. Because again, every dollar that you don't spend of that 5,000, 8,000 limit, whatever it is, they get the pocket. And then finally, they lemon drop, which is those beneficiaries that you know, are seriously, their health fails, you know, and they're more costly. They cut from their programs. They just drop them. And so those folks are forced to, you know, to find another program. And in not all states can you go back to Original Medicare, or let me put it this way, it's called guarantee issue is the technical term. You can go back to Original Medicare, but there's no guarantee that a Medigap policy will be sold to you. So it could be a death warrant. You know, if they drop you out of Medicare Advantage and you're in a state that doesn't guarantee a Medigap policy for you, and you have serious health issues, it could bankrupt your family. It could totally impoverish you. Okay, not a pleasant story. So those are the cons of Medicare Advantage. So if you're healthy and you want those extra benefits, but also if you're low income, it's less costly, but if you're healthy, maybe it's going to work out really well for you. If your health is not as good and you get into that buzzsaw of delays and denials, you're in a world of hurt. But that's not all. In 2016, during Trump 1, now he didn't come up with any of these ideas, but he rubber stamped them. The Center for Medicare and Medicaid Services, which was in CMMI, was created from the ACA back in 2009. Unfortunately, the heads of CMS, it's a revolving door from the insurance industry to CMS, and that's the agency that controls Medicare. The woman who now is in the head of it is Dr. Liz Fowler. Dr. Liz Fowler, I've talked to her, she's very bright, she's super articulate. She was Senator Max Baucus's chief of staff, chief of staff and healthcare expert during the ACA negotiations. And she is responsible for the main reason why we do not have a public option in the ACA and why the government is not allowed to negotiate with pharmaceutical companies over prescription drugs. Those were her recommendations to Senator Baucus, who was head of the Finance Committee, which basically told Obama, not going there. She runs CMS right now, okay? So, under Trump 1, they created something called direct contracting enterprises, which basically opened up Medicare Advantage programs beyond the insurance industry to any corporation in Wall Street. Okay, so a few years ago, Amazon bought One Medical, which owns Iora. Both of those companies make a majority of their money from Medicare. Okay, they spent nearly $4 billion purchasing those two medical outfits. Okay, why did they do that? Well, I'll tell you in a second. But before I get to that, so remember I said Medicare Advantage, they were allowed 15% off the top? Well, DCEs, we did we did, not PSARA, but members of Congress. I mean, PSARA was a little tiny part of it, but Physicians for Social Responsibility, Physicians for a National Health Plan, and others lobbied and beat back the DCA program. But when President Biden was elected, Liz Fowler changed the name, and Biden accepted it. It was called the ACO REACH program. Accountable Care Organizations Reaching Equity, Access, and Community Health. Man, it's a great sounding name. You know, it's like, wow, everything you'd want in healthcare, right? Yeah, well, what it allowed was these ACO REACH's medical advantage programs to take 25% off the top, okay? So 25 cents of every Medicare dollar went to them, and that's before any of the upcoding and all that kind of stuff, and only 75 cents to health services. What's going on here, and why has there been a gold rush of corporate America running into Medicare? Well, in 2020, right now, this year, we spent about $1.3 trillion in Medicare expenditures. Okay. By 2028, they're projecting annual Medicare expenditures will be $1.6 trillion. Okay, so original Medicare, 2% of that. That's $32 billion. That's a lot of money, but that's to administrate a very big program that covers, you know, some 75 million people. Medicare Advantage programs, remember 15% off the top? That's $240 billion out of 1.6 trillion. ACO REACH, 25%. That's $400 billion out of 1.6 in Medicare expenditures. You're getting the idea, right? This is the goose that laid the golden egg. This is where the money is. In fact, last year, an executive from Humana, the insurance company, said they are leaving the employee health insurance industry. Why? Because he said, and I quote, Medicare is now the cash cow. Okay. CMS under Liz Fowler, I had this in writing from her, she said they expect every Medicare beneficiary by the year 2030 to be part of an ACO REACH organization, a Medicare Advantage program. You know, when PSARA started this battle to protect Medicare, original Medicare, 55% of retirees were in original Medicare. This past year, it's now down to 46%. Medicare Advantage has been growing each year. Okay, so here's the final piece on this, and then I want to open it up for questions. So under Trump 2, there's yet another wonderful idea of his, not his, but Liz Fowler. It's called the WISER program. Okay, it's a new pilot program. It's scheduled to go into place January 1, 2026 in 6 states, and it impacts original Medicare. The states are Washington State, New Jersey, Oklahoma, Texas, Ohio, and Arizona. WISER, it's an acronym for Wasteful and Inappropriate Service Reduction. I mean, you know, even Elon Musk couldn't come up with a better acronym than this. I mean, this is kind of Doge on steroids. What it allows is for, it introduces prior authorization to original Medicare for 17 specific medical procedures, okay? It's a pilot, all right? So in these 17 specific procedures, the decision between you and your doc is abrogated, and it's the insurance company or CMS directly that makes the decision for you. And it allows AI to make the decision. I mean, what could go wrong, really? And I know this is hard to believe, but it's in writing, the contractors are compensated on what they're calling a bounty system. And I quote, payments are based on the share of averted expenditures. So the more cost, the more you lower the cost. How do you lower the cost with prior authorization? You deny, you delay, right? The higher your payments are. CMS has a justification for this, so I mean, it's not like they're just kind of saying this stuff and then snickering on the side. There are those fools out there that never understand. They put out a justification for it, which at first glance you go, oh, okay, maybe it makes sense. They refer to a report put out by MedPAC. MedPAC is a legislative agency that's nonpartisan, independent, and it provides, again, it came out of the ACA legislation in 2009, and what it does is provides objective factual information to the Centers for Medicaid and Medicare Services. And MedPAC reported in 2022 that $5.8 billion in Medicare was spent on services that had little to no clinical benefit. Waste, okay? I mean, they weren't really necessary. No proof that they did any good. What they don't point out in the report, but if you read the report, you'll find it, is MedPAC also estimated that CMS will waste $84 billion overpaying Medicare Advantage companies through fraud and overpayments. So Weiser, oh, and I should say this too. MedPAC determined that in 2023, 80% of prior authorization denials in Medicare Advantage programs were partially or fully overturned. Okay, so not a good track record. Are we doomed? No. Never give up. Never say doomed. Senator Murray, Patty Murray, has it's about a 90-second video, and you can, if you Google Senator Murray Weiser, W-I-S-E-R, it'll pull up this video, and it's what she excoriates, private industry for this, and says we cannot allow this pilot to go forward. Representative Del Bene and 23 co-signers just put a bill into Congress that would not allow Weiser to take effect. Representative Larson did sign on it. Representative Jayapal, Smith, Schreier have all written letters opposing Weiser. And Jayapal has been a crusader both for Medicare for All, but as well going after the fraud in Medicare Advantage programs and the ACA REACH programs, and now Weiser. Representative Pocan, who was a former chair of the Progressive Caucus in Congress, has a great bill going after Medicare Advantage fraudulent behavior. Ro Khanna from California does as well. Elizabeth Warren and Senator Bernie Sanders all have been heroes in fighting for original Medicare. PASAR, as I mentioned before, we started 5 years ago this level the playing field strategy, and it's now been picked up by some national organizations. And when we first introduced the idea to them, they basically said, well, you all know you're a little statewide organization, you're in the peanut gallery, we're gonna keep talking about these other things, and we wanna bang on Medicare Advantage. And we decided that we weren't gonna bang on Medicare Advantage, we were gonna tell the truth about it, as long as we could back it up with facts, and tell our own members that we're in MA programs. If they like them, that's fine. Okay, just be aware that you could get caught in the meat grinder here. And decided to do the level the playing field, because we know that if we can get the premiums down to $20 a month in original Medicare and no prior approval, right? So that it's you and your doc making the decisions. And if we can introduce limited, some vision, dental, hearing, home care, transportation, gym membership, stuff like that, then it's gonna be a no-brainer. Folks are gonna say, I'm picking that over the Medicare Advantage program. Because in Medicare Advantage, again, it's prior approval. It's not you and your doc making the decisions. So anyway, there's hope yet. I'm gonna stop there at this point and see if people have comments, questions, wanna razz me, that's fine, yes,
You said the Wiser is a pilot program.
yes,
Does it have a time frame?
yes.
What's
So
that?
it will go into effect, if not stopped, January 1, 2026, so in about a month and a half.
Right, that's the pilot program
Yes.
starts. I just wondered, is there length of time for the pilot program to run? Or is that
Yeah, you
wide
know,
open?
that's a good question, and I think in the article in this issue of the Retiree Advocate, it may actually say, I just can't remember. Typically they do these pilots for 2 or 3 years. But I'm guessing, given the Trump administration, they would want to expedite that because, again, their goal is to privatize Medicare completely, right? And this is the biggest incursion into original Medicare since 1965.
You mentioned it covers 17 areas of medical expenses, I guess. What are some of those?
Yeah, shoot, I should have
I
looked
got
that
some
up.
spinal surgery coming up.
That's
It may fall this year, it may fall early next year. I'm just wondering.
Yeah, so I will find that out for you and
That's
send
okay, I'll look
it to
it up.
Barbara. But yeah, you can Google it as well,
Yeah.
just Wiser, and what are the 17 procedures
Yeah.
that they covered. Yeah,
Thank you.
yeah, yes.
Okay, let me
Oh, sorry.
give you the mic and can you introduce yourself and.
Okay, thanks. Yeah, this is really an eye-opener, and thank you for coming. I have a question that's a little bit different from what you're talking about. It has to do with the original Medicare and the hospital's doctor's complaint that the amount that the Medicare provides for a surgery procedure is far less than what it actually costs, and could you talk about that and how that amount is determined? And I understand from my Medicare mailings that there's an additional local consideration too that's on top of that, it drops it down considerably from what they actually claim or are charging.
Yeah, so I'm gonna give you an inadequate answer. I'll be upfront with you. I'm not an expert in Medicare finances, but you're right. For decades, there have been complaints that the Medicare reimbursement rates are not high enough, okay, for physicians or for hospital services, and particularly in rural areas where it's hard enough to get adequate healthcare services. The problem at this point is that the Medicare Trust Fund has been so depleted by the outright fraud from these medical advantage programs that there's even less money to actually raise, reimbursement fees. So we're in a pickle right now, unless Congress, part of our level the playing field proposal is to not only give the same benefits to original Medicare and the cost structure, but it's also to make the insurance companies pay back what they defrauded from the system, and not allow them to continue insuring for X period of time because of that fraud, right? So that we could build back up the Medicare Trust Fund, and you could actually have a reasonable debate over what are appropriate fees, because you are right, the fees are not, in all areas, are not high enough to actually cover the services.
Yeah, my question is more geared to what is the process here? I understand, like, there's a board of doctors who decide how much this thing should actually cost, and is that fair? Is that structured in a way that is fair to the hospitals or not really?
Yeah, so I'm gonna beg off on the question. I'm not sure I have a really good answer for you. I mean, I know that the rates are set through CMS, and I know they have a board. I know they have consultations, but I also know that for several decades, and you probably remember this from when you chaired the healthcare committee, right? That they've been complaining about being under the fees being under the required rate for decades and decades.
Actually, in partial answer, Medicare
Use
reimbursement.
mic.
In partial answer, Medicare reimbursement rates differ from area to area. So reimbursement, for example, for Island Hospital is less than Skagit Regional. And neither Island nor Skagit Regional have book has to say about that. There is no panel of local doctors at the facility that sets any fees. The hospitals simply know what it costs them, but all they can do is accept the reimbursement that Medicare offers. And it's really counterintuitive, because a smaller community hospital or a rural hospital, for many reasons, has higher expenses. And it does play into also staffing, why a smaller place may have more difficulty attracting the staff that they need. So it's fairly complicated. If I might, Jeff, you didn't mention anything about co-pays in Medicare Advantage.
Right.
Would you comment on that?
Right, well, yeah, I'm not part of Medicare Advantage, so I don't really know. Can anyone tell me who's in Medicare Advantage, what the co-pays look like? Yeah, Rita,
Kaiser
okay, yeah,
and Advantage, it's $30.
$30, okay.
For some,
For every visit?
$50 for PT, isn't it?
It's what?
We
Isn't
pay
it?
35
Yeah.
35?
for a visit with
I
a,
got the state retirement,
Okay,
and it's 30, I think there's no co-pay for once
Okay.
a year
okay.
check in.
So, and are there other co-pays that you make in a Medicare Advantage program?
yes.
Yeah.
Specialist is $50.
Okay.
There you go.
Okay,
And for procedures, it can be like $150.
okay,
Recent hospitalization cost about, I mean, of course, the bills were very high, but
right,
what we ended up paying was, I don't know, around $1,000, I think,
Okay.
for several days hospitalized.
okay.
Steal the deal to us.
Okay, so let me juxtapose that to this though, okay? So, all right, that doesn't sound very good, but with original Medicare, you know, Becky and I, we don't have to pay co-pays, right? But, you know, $1,600 is the limit for hospitalization, but if they're out-of-pocket expenditures, there is no limit. Whereas an MA program is $8,300, right? But our Medigap policy costs us $6,600 a year. I'd have to rack up a lot of doctor's visits to get even close to that, you know, so it still cost-wise seems to be an advantage. Again, comparing that to all the disadvantages. I mean, basically, I believe Medicare Advantage, as my wife said, really is advantageous to the insurance companies and fairly disadvantageous to Medicare beneficiaries. Yeah.
And another advantage of Medicare Advantage is 0 premiums.
Yes, no, that's the huge one, and,
Yeah.
you know, when you look at the data, and this is what breaks my heart, you know, because, you know, I mentioned, you know, racism lay at the birth of Medicare, to get it past the Southern Senators, to actually get the vote. They created that Medigap problem, that 20% cost problem, you know, again, to penalize people of color. Well, when you look at the data right now, Medicare Advantage is really the people of color, black and brown people, more often than not go into Medicare Advantage programs because $20 a month is easier to afford than an average of $200 a month. And yet those communities typically have worse health profiles. They're more likely to get delayed and denied benefits. They're more likely to get cut loose if they cost too much money. And so what they can afford ends up being really bad health care in the long run for them. And it's a huge tragedy. Other thoughts, comments? Yeah.
I just wondered if you were dropped from Medigap, can you get on the original Medicare afterwards?
Well, if you're dropped from a Medicare Advantage program, yeah, you can get back during the open enrollment period back onto original Medicare. But again, there are certain states that have guarantee issue, which means that insurance companies are required to offer you a Medigap policy. Washington State is not a guaranteed issue state, okay? So my co-president at PASARA, Karen Richter, she and her husband were on a Medicare Advantage program, after we started doing all this research and all this organizing, they said, we're getting the hell off, and we're going back to original Medicare. They were lucky because Regions picked them up. So they were able to get a Medigap policy, but Regions didn't have to pick them up. So you could be out of luck. And again, in states that don't have guaranteed issue, and if you're, you know, a low-income family, whether white or person of color, and you get dropped, you may be minus that 20%, which basically means you're just plumb out of luck. You know?
I applaud your effort to level the playing field between Medicare and Medicare Advantage, but in order to do that, you have, you know, Medicare is going to have to take on additional expenses.
Yes.
And if things are so strapped as it is, maybe I'm a skeptic, but what do you think the odds are of you accomplishing that?
Right now, the odds are zero, but you know, if we had a Congress that had a backbone and said, we're gonna make those insurance companies who are making money hand over fist pay back what they defrauded and what the inspector generals can actually prove, because they can break it down by insurance company. They can say, you know, United Healthcare, Humana, this is how much you've defrauded the Medicare Trust Fund. If they got that back, you know, the $125 billion would pay for hearing, dental, vision, you know, a whole bunch of those services. Would it pay enough so that you could actually lower premiums in original Medicare down to $20 a month? Probably not. It would need more money than that. Yeah. I mean, it's an expensive venture.
Yeah.
I think if you just could make it simple, like the Medicare Advantage,
That would be.
that would make a big difference.
Yeah, it would.
That we have to consider so many multiple decisions that we have to make up in order to get the coverage.
That's right. That's right. Yeah. All right.
As a person from the great state of Texas, I apologize. I'm a political refugee.
But here's.
Yeah, and a UAW member also.
All right, very good. So I should say this here. So Representative Doggett from Texas.
Yeah,
Okay. Lloyd, okay. I don't know him on a first name basis, but you apparently do. So he has been a warrior for equalizing the benefits between Medicare Advantage and original Medicare. So he has a bill in that would provide dental, hearing, vision. That's been his.
Yeah.
Oh,
Yeah.
Excellent, excellent. All right. Well, anyway, please take the literature in the back, and you know, and if you thought it was interesting tonight, and if you have $20 a year to join PASARA, you get a wonderful. It's the best non-award-winning newsletter in the country. And just you know, and it's not all just serious stuff, because I mean, well, it's all serious, but like there's an article in here that said, "Meet Jean Ross, the real Sally Bowles." So you all may remember the movie and the play Cabaret that at Lisa Minnelli, she played the part of Sally Bowles. Well, here's the real history of Sally Bowles. So we do culture and all sorts of stuff anyway. You've been great, thank you.
PSA, since most, if not all of us in this room are on one form or another of Medicare, because Medicare Advantage does require prior authorization for so many things, where original Medicare does not. It means that there are far more denials for care if you are on Medicare Advantage. Only 11% of people who have had their physician's recommendation denied will appeal that, but 85% of those appeals will succeed. So if you are denied, appeal it.
Appeal. That's right. That's right.
Are there any other questions? Okay.
Thank you.
Another question.
Not exactly a question, a comment. Back to the early 70s, we had group health.
Right.
As our insurance.
Yeah.
And when it transitioned to Kaiser, I was working for the state.
Yeah.
You know, we went to Kaiser. It's been fine. When I retired, we went to Kaiser. Med Advantage. And we haven't had any problems. My husband's got really complex health
Yep.
issues.
Yep,
We've had no issues, and one of his issues is a retina issue
yep.
that would not be covered if
Yep.
we didn't have.
No, I'm glad you said that, because a lot of our members are in the Seattle, greater Seattle area, and many of them started off with group health, which was started by the Longshoremen's Union way back in the 30s, and became Kaiser, and they liked their Kaiser program. You know, so we have to be pretty careful the way we talk about this stuff with our own members even, and that's really where the level the playing field strategy came from. It's like, let people choose, but give people a real choice. Because right now, there's not a real choice. I mean, if you're on a limited income basis, you're going Medicare Advantage 9 times out of 10. Because one, because you don't know all this stuff, but two, because it fits your pocketbook.
Are there any other questions? Comments? Thank you.
Oh,
Thank you for